the 16th, 1846, one of the great dates in the history of medicine. Before it, the screams, the cries, the moans of the operating theatre. After it, the peace and quiet of modern surgery. The surgeon picked up his knife, dissected out the cyst. Nothing happened, not a murmur. Was he alive or dead? Within a minute or two, he stirred and sat up. The crowds went wild. Warren turned to them and said, "Gentlemen, this is no humbug."
The image of the surgeon now is of a man who exercises an impressive skill with every hope of success. 150 years ago, when this theatre was in use in the 1830s, a very different surgeon worked in a very different setting.
You, come down here and be a patient. Poor fellow, lie up there. Porters would leave us, and then we need, in a non-teaching hospital, two really strong, hefty men to hold the patient down at the first touch of the knife on the flesh. You and you. Excellent chaps. And the job of the students or the porters, of course, was to keep the patient. They were the anaesthetists of those days. Now, we've got chairs there in front of you for important visitors who wanted to see the show. That's why, of course, theatres are still in this country called theatres to this day, although in the USA they're called operating rooms. Floor would be covered with sawdust to sop up the blood and sometimes the vomit, and there'd be a box here full of sawdust which would be pushed by the surgeon under the part that was bleeding to catch the blood. No ventilation except by opening the window. No air conditioning, so it would be blazing hot in summer. Many of the students would faint. Freezing cold in winter. No plumbing. There'd just be one bowl with a jug of water for the surgeon to wash his hands, not at the beginning of the operating list, of course, but at the end of the operating list. The surgeon would come in through this door here, take off his jacket, hang it on the hook, and pick up his favourite operating frock coat. Frock coats stained with the blood and pus and secretions of 100 operations. In fact, the more senior the surgeon, the filthier the frock coat. Now, as I said, time is going to be of the essence in those pre-anaesthetic days. Every second was going to be minutes, every minute, hours. Patients would go to the surgeon who had the reputation of being the quickest. And of course, surgeons had to have nerves of steel, because they would be operating against the clock with a screaming, struggling patient. Many young men aiming to be surgeons gave up medicine. They just couldn't face the horrors of this room.
Yet surgery had already come a long way. The predecessor of that surgeon was a very rough character indeed. Surgery was a brutal craft, which the apprentice picked up from watching his master. He was often also the local barber, another craft needing well-sharpened instruments. The surgeon had very little in common with the much more highly educated physician, and was not allowed to call himself doctor. British surgeons today still use the title Mr. The name surgeon is derived from the Greek for hands. No one expected these surgeons to use their brains.
there was medicine as practiced by the clerics, who were specifically banned from actually getting blood on their fingers. So this meant that the surgeon was a humble man, a craftsman, called in to work at the direction of the doctor or the physician, because the physicians couldn't actually operate themselves.
The range of operations performed by these manual workers was limited mainly to repairing the ravages of battle, and it was with the military surgeons that the road to respectability began.
It was only on the battlefield where the injury had carried out, as it were, an entry to the body, which the surgeons themselves were frightened to make. They were forced to follow on and try and sort things out and repair things. And this actually, as it were, the injury and the severity of the injury was forcing the surgeons to go where they wouldn't normally dare to go in peacetime.
One thing that experience of the battlefield taught the surgeons was that even minor wounds were extremely dangerous.
The main problem with certainly wounds of the limbs in wartime is the fact that without surgery they inevitably become infected, partly because of this massive contamination with dirt and bacteria which goes in at the time of the injury. The only way that the ancient surgeons perhaps could get rid of this was by amputating and therefore cutting away the whole part that was concerned.
And amputation was only the beginning of suffering. Surgeons believed the correct way to finish the operation was to dip the stump in boiling oil, while the raw flesh of gunshot wounds would be cauterized with red-hot irons. In the 16th century, when Ambroise Paré became a military surgeon, he was taught this as the one safe procedure.
It was only, in fact, Paré who initially discovered by accident, because of the one day when he was a young military surgeon, he ran out of oil. And he could think of nothing else to do, but instead of putting boiling oil on, to put on a bland mixture of egg yolks and various other things like that. And he describes how he spent all night after this, wondering how on earth his patients were going to survive, because he had done, which was quite the non-standard treatment. And he was terrified that when he woke in the morning, he would find them all dead or in a terrible state. And of course, when he got to their tent in the morning, they were all far better than they would normally have been. And he, from this, deduced that perhaps boiling oil was not the best thing to do.
Paré became known throughout France as an outstanding and humane surgeon, and his influence reduced some of the calling's worst brutalities. By the 1830s, the surgeon had gained in respectability, but surgery remained a crude and cruel business.
Now let's pretend, it's only going to pretend, that we're going to amputate this young man's leg. Now what we will need is one of the assistants will hold the leg up for me like that, you see. The other assistant, we won't put it on because it would be painful, he'd put the tourniquet around the thigh, or alternatively sometimes just press onto the femoral artery at the groin, at the pressure point. The two of the strongest medical students we find would hold the patient down, if you don't mind, and we're ready. I'd get my sawdust ready under the leg. House surgeon would give me a knife. 2 quick sweeps, front and back, would turn back the skin flaps, which I'd turn back with my fingers. Drop the knife on the floor. Amputation knife. Wrong knife. The amputation knife would be slid along the bone, at parallel with the bone. Turn the blade up through the muscles of the thigh. Through back behind the femur, turn down through the muscles of the back of the femur. Drop the knife on the floor. Saw! Few sweeps of the saw, turning back the muscles in my hand, leg amputated, thrown into the sawdust. The screams would turn into sobs, call the porters, take the patient back to the ward. 30 seconds would be about par for amputating at mid-thigh. Thank you very much. Didn't hurt you? Oh, excellent.
But in 1830, the unfortunate patient, even if he survived the surgery, might well succumb to infection or bleed to death.
Well, horrible though that scene was, primitive, painful, gruesome, it was the best that scientific surgery had to offer 150 years ago in one of the premier teaching hospitals in Europe.
Few patients would submit to the agony of the knife, so the surgeon's repertoire was limited. They ranged from cesarean sections to the awful cutting for stones.
It's interesting that bladder stones were very, very common at that time. They're not nearly as common now, thank fortune. They were terribly painful. And after a man had gone through this awful pain, it was commoner in men than in women, for many years, finally he was willing to submit to this terrible, dreadful operation of cutting for stones, which was done without anesthesia, had a high mortality. But sometimes it was successful and the patient could go back to his regular life again. Cesarean sections, of course, were done without anesthesia. The abdominal musculature of a woman in the 3rd trimester of pregnancy, getting ready, her abdominal muscles are very, very loose, and it's possible quickly to empty the uterus. Now, the original cesarean operation, of course, was done with the mother dead, and the fetus was to be saved. But in the days before anesthesia, cesarean section operations were done, of course, with survival of both the mother and the fetus, but it must have been a terrifying procedure.
For surgery to advance beyond a brutal craft, 3 main barriers had to be overcome: the control of blood loss, the elimination of surgical infection, and above all, the conquest of pain.
They did everything they could to assuage the agonies of the operating theatre. They dosed the patients with brandy till they were as drunk as newts. They dosed them with laudanum till they went dizzy. They used hypnotism, they used mesmerism, but the first touch of the knife onto the skin, and that was in vain.
They used alcohol, of course. People often got pretty drunk before operations. They gave a lot of morphia and laudanum and other heavy drugs of that type. And we have reason to believe from pictures a little earlier than that in the 16th century that actually they would have a boxer or a rather tough fellow off the street with a boxing glove on who would try to knock out people before operation. Seems incredible, but evidently that was done. So they did do things, but many people, as the military surgeon said, they'd give the soldier a bullet and tell him to bite that bullet, and then they would amputate the leg in very fast time. And it just seems incredible suffering, and yet many lives were saved, and it's quite surprising the operations they did.
In 1809, in the living room of this house in Danville, Kentucky, the surgeon Ephraim McDowell performed one of those exceptional feats of surgery. His patient, Mrs. Jane Todd Crawford, was suffering from a gigantic tumor of the ovary. A truly heroic lady, she traveled 60 miles on horseback to get here. As McDowell prepared to operate, an angry crowd gathered outside, threatening to shoot him if his patient died.
I made an incision 9 inches in length into the cavity of the abdomen. We cut open the tumor and took out 15 pounds of dirty gelatinous substance, after which we extracted the sac, which weighed 7 pounds and 1/2.
The operation lasted 25 minutes with no anesthetic. Mrs. Crawford lived to the age of 78, so her suffering was rewarded. Yet she could have been saved so much agony if her surgeon had known of research done 9 years before on the gas nitrous oxide. The work was done by the chemist Humphrey Davy, and when he came to publish his results, he described the pain-killing effect of breathing the gas and suggested its use in surgery. Unfortunately, the book's obscure title meant that it went unnoticed by most surgeons. Davy called his preparation laughing gas, and cartoonists had plenty of ideas for its use. Nitrous oxide was only one of several vapors which people inhaled for fun. Another was ether. Demonstrations of their effects became part of the music hall. It was a young dentist called Morton who forced the surgeons to take notice. He had been to a show and seen the effects of ether. He realized that those who breathed the vapor were not only intoxicated, but were also unable to feel pain. Morton took his discovery to Massachusetts General Hospital, where it was tried out during an operation by one of the most influential surgeons in America, Professor John Warren.
distinguished man in his time, now famous for doing a minor operation. Because the operation that was done was on a young boy called Gilbert Abbott, a young lad of about 17 or 18, who had a little simple cyst in his neck. Room was packed. It was a room like this with students and surgeons who heard some miraculous thing was going to take place. Morton gave the anesthetic to Abbott using the most primitive apparatus, a simple glass sphere with a sponge in it soaked in ether. Abbott sucked at the ether. Within a few minutes, Morton said, "Your patient is ready." Students held the patient as hard as they could because they knew he was going to struggle and fight. Warren picked up his knife, dissected out the cyst. Nothing happened, not a murmur. Was he alive or dead? Within a minute or two, he stirred and sat up. The crowds went wild. Warren turned to them and said, "Gentlemen, this is no humbug." Modern anesthesia brings out the poet in the surgeon, you see. October the 16th, 1846, one of the great dates in the history of medicine. Before it, the screams, the cries, the moans of the operating theatre. After it, the peace and quiet of modern surgery.
A commemorative photograph was taken, but not until 2 days later when the group reassembled for the purpose. They had, after all, made history. Warren immediately went on to use anesthesia in major operations, and the surgical hierarchy was converted. Within 2 months, a report appeared in The Lancet, published in London. It came to the attention of Robert Liston, senior surgeon at University College Hospital.
Magnificent man, 6'2", tremendously strong. It was said that he could hold the leg with one hand, compressing the femoral artery, and amputate with the other hand, like that. He was so strong. Fastest time, 28 seconds, in which he removed not only the patient's leg, but also 2 of the assistant's fingers and the patient's left testicle, all with the same sweep of the knife.
The patient today, Frederick Churchill, also needed a leg amputated.
Liston came in and, turning to the audience, said, "Gentlemen, in this room you've seen me try and assuage the agonies of the knife," he said. "You've seen me use hypnotism and mesmerism. You've seen me use alcohol and laudanum. But today we're going to try a Yankee dodge to render men insensible," he said. "Time me, gentlemen," he said. All the watches came out. They held up the leg, put on the tourniquet, amputated the leg. 28 seconds, one of the students got out. The leg was off. Bandage was put on. Was he alive or dead? Absolute silence in the operating theatre. Churchill stirred. "Take me back to the ward," he said. "I can't go through with it. Let me die as I am." Liston held up the bandaged stump like that. Churchill burst into tears. Porters carried him away. The crowds went mad. Liston said, "Gentlemen, this Yankee dodge beats mesmerism hollow." I tell you, it brings out the poet.
Liston's anesthetic machine, like Morton's, used ether. But ether, though effective, was unpleasant for the patients to breathe, so a search began for a substitute. James Young Simpson, a fashionable Edinburgh obstetrician, liked to try out new chemical substances with a group of medical friends after dinner. On one occasion, their experience was dramatic.
On awakening, Dr. Simpson's first perception was mental. "This is far stronger and better than ether," said he to himself. His second was to note that among the friends about him there was both confusion and alarm. Hearing a noise, he turned round and saw Dr. Duncan beneath a chair, quite unconscious and snoring in a most determined manner.
This was chloroform, and Simpson extolled its virtues.
Most of those who know the sensations produced by ether inhalation and who have subsequently breathed the chloroform have strongly declared the inhalation and influence of chloroform to be far more pleasant than those of ether.
The first time Simpson used chloroform, his patient gave birth to a girl. The grateful mother christened the poor child Anesthesia. For a while, it seemed that chloroform would take over from ether.
But within a year of its introduction, a girl of 11 died in the dental chair from being given chloroform for the extraction of teeth. And that was the first shadow. And then more deaths were sudden, unexpected deaths in perfectly fit people very early on in the inhalation, unknown in ether. They might die later, but not so early on, and this became a frightening thing.
Patients who were given too much chloroform stopped breathing. Attempts were made to solve the problems with more sophisticated apparatus, but the chloroform deaths continued, so most anesthetists returned to ether. It would remain the leading anesthetic for a century, despite its unpleasant effects. Apart from a few diehards who argued that pain helped the healing process, surgeons were quick to adopt anesthesia. They were slower to realize that it not only relieved pain, it also gave them more time.
They've been generations, of surgeons have been taught to act quickly and to work quickly, do an amputation in almost seconds. So it took them a very long time indeed to adjust to this new potential.
James Syme of Edinburgh was one of the first to exploit the extra time that anesthesia gave. Syme pointed out that when bone was diseased, as in this elbow joint, it was no longer necessary to amputate the whole limb quickly. There was now enough time to pare away the diseased portion of the bone and reconstruct the joint, leaving a useful limb. But pain-free surgery exposed the second major barrier to surgical advance: infection.
But what about the filth? What about the stench? What about the disgusting frock coat? What about the sponge taken from one patient to the other and seldom, if ever, washed? The filthy hands. Well, you see, the fact of the matter is, this was decades before the germ theory of infection. Surgeons were all too familiar with sepsis, infection, putrefaction, hospital gangrene. Sometimes the mortality went up to 100%. And they'd shut the hospital. They'd even burn the hospital down, rebuild it. But they didn't know what caused it. They talked about a miasma, some sort of vapor that spread through the hospital wards. Little did they know that the miasma were the bacteria on the surgeon's hands.
Anesthesia made surgery possible, you might say, major surgery, but it still wasn't safe. And reading the case records of those times is absolutely dreadful. They would do simplest little operation and be followed by gangrene and terrible streptococcus infection. Of course, they didn't know anything about microbiology.
When you finished cleaning your car engine, do you go and have a bath and put your evening jacket on before you empty the vegetable waste onto the compost heap? Of course not. You wait till you've finished all your filthy jobs of the day before you tidy up. So the surgeon would go from the filthy, stinking dissecting room into the filthy, stinking ward, into the filthy, stinking operating theatre, and only when he'd finished all his filthy, stinking duties for the day would he go home and have a bath and clean up after his day's revolting tasks.
Why did they persist with their unhygienic ways for so long?
Well, I think it's because people didn't really understand the concept of bacteria, or what was called the germ theory of disease, that you could take something from one patient and give it to another. Several historians of surgery describe the period between the discovery of ether and the work of Lister, which we'll call 1870, as the black period of surgery, because operations were done that shouldn't have been done and the results were terrible.
The chemist Pasteur signaled the way out of surgery's black period. He had discovered bacteria and showed that they were involved in spreading disease. Pasteur's work was described to Joseph Lister, professor of surgery in Glasgow, and he determined to find a way of poisoning these bacteria, which it seemed were killing his patients.
Well, the professor of chemistry in Glasgow was a friend of his, and the professor of chemistry in Glasgow said to Lister, there's a marvellous new process they're using in the sewage works in Carlisle. They're putting carbolic into the sewage, and it cuts down the smell. Now, Lister knew very well that the smell of a sewage works was extremely similar to the smell of the operating theatre and the surgical wards. So he got some carbolic, and he decided to kill the microbes using carbolic acid. And the crucial experiment was in August 1865.
A child, James Greenlees, had broken his leg. Lister should have amputated because this was a compound fracture. The bone had broken through the skin, and a lethal infection was bound to follow. But he didn't amputate.
What Lister did was to apply phenol, which is a mild antiseptic in the concentrations he used, directly to the protruding bone and to the tissues around it. And he cut away the tissues that had been damaged, and then he just immobilized it and let the patient's own local inflammation begin to overcome it.
Amazingly enough, when he took the dressings off a few days later, instead of the usual stench and the pus and all the classical signs of inflammation, the wound was healthy. Something was absolutely amazing, something nobody could imagine they'd ever see. The leg healed, Greenlees went home. Lister didn't say anything about this because he was a scientist. He waited until he'd collected a total of 11 compound fractures, 1 death from hemorrhage. 1 wound went septic and the patient lost his leg. 9 patients walked out of hospital with their limb intact and the wound healed, and you didn't need to be a statistician to realize something important had taken place. It was a miracle.
In Lister's operating room, antiseptic technique was carried further. Believing that airborne bacteria were a major source of infection, he performed all his operations in a damp mist of carbolic, produced by a spray pump. The system was extremely unpleasant and difficult to use, but Lister's staff suffered in silence, though one irreverent soul was heard to intone at the beginning of an operation, "Let us spray." But despite its success in Lister's hands, the carbolic regime was not quick to catch on. Surgeons elsewhere were unconvinced of the need for this troublesome procedure.
The carbolic itself does kill tissue. And if you just put it on living tissue, it will turn white and will be killed. But then behind that, the healing reaction comes in. So it could do harm and had to be used carefully. And the people that didn't like it, what we would call the doubters, were collecting cases where at least they thought the patient had been badly harmed by it. America was very slow. There was a conservative faction in surgery that said we shouldn't change. And in a way, medicine, science, fields of learning always have the conservatives saying let's not change our thinking and the radicals saying let's change. There's always a tension there. It's a healthy tension. And in this country, we were slow, but finally, of course, we did.
One of the first American surgeons to take up Lister's ideas was William Halsted of Baltimore, a man who would dominate American surgery for 3 decades. Halsted had studied in Europe, where he had been converted to the virtues of antisepsis. But at the moment, the antiseptic regime was presenting him with a personal problem. His nurse, Miss Caroline Hampton, was allergic to the carbolic. The rash on her hands became so severe that she threatened to desert her post. Halsted had seen excellent results from following Lister's techniques, and he was loath to abandon them. On the other hand, he was most upset at the prospect of losing Miss Hampton's services. So he contacted the Goodyear Rubber Company and asked them to make her some rubber gloves. The reason for Halstead's extraordinary solicitude became apparent the following year, when he and Miss Hampton were married. These were the first surgical gloves. They were to protect Miss Hampton's hands from the antiseptic. Later, gloves would be universally adopted to protect the patients from the surgeon's hands, which Robert Koch, the German bacteriologist, had incriminated as a prime source of wound infection. Koch had invented techniques for studying and identifying different species of bacteria. With cotton swabs, he took samples of the bacteria living on the hands and fingernails of the surgeons and grew them in test tubes alongside blood from infected wounds. On examination, he found that many of the cultures were identical. He proved that some of these bacteria were harmless, but that others led to fever and death. The harmful organisms had to be prevented from ever reaching the patient's wound, and Koch experimented with ways of killing them wherever they were found. He showed that boiling was far more effective than Lister's carbolic acid. From now on, the problem of infection would be handled differently, not by antisepsis, but by asepsis.
Antisepsis means the infection is there, you're going to do something. You're going to kill it with a phenol or whatever you were using. But asepsis means setting up a completely sterile field. And the typical Hollywood pictures we see so often of all the masks and gowns and all the white things in an operating room, which is perfectly true, that is the setting up of a sterile field, which is called asepsis or aseptic technique.
Surgeons were slow to change their ways, with disputes about what was and was not necessary. In the mid-1870s, operations were often performed on the ward. Only gradually did they begin to use designated hospital rooms. Special operating room clothes became standard, and this time they were cleaner than normal clothing. At first, some surgeons worked in large amphitheaters with an audience in everyday clothes. This increased the risk of infection, but it was argued that students must be able to watch the new operations being developed. At centers like Vienna, where Theodor Billroth was advancing surgery of the abdomen. The amphitheaters disappeared when the audiences became smaller. Some said because surgery lost its excitement. The patients now tended to survive. In William Halstead's operating room, where rubber gloves were first worn by Miss Hampton, surgeons now adopted them as an aseptic precaution. At first, Halstead himself only covered 2 fingers and thumb, because, like many surgeons, he was worried that the gloves would make him clumsy. But he soon adopted the full gloves as he developed new operations where the wounds were very large, too risky without good control of infection. And his team wore hats, as it was observed how fertile a source of bacteria hair could be. And finally, masks were adopted, at first by surgeons only, later by everyone in the operating room. Changes in the surgical environment called for the backup of a new technology. Systems were developed for sterilizing everything that might contact the patient's wound during an operation. The best method was usually the steam autoclave, which left everything dry and ready to use. But instruments could also be sterilized by soaking in a bath of the stronger chemicals now available, or even in a gas oven with tablets to produce bactericidal fumes. Now a great era of expansion began. Surgeons no longer had qualms about opening the abdomen, and heroic operations which had been rare became widespread. Sometimes they were successful, but sometimes they encountered a problem that at first was as mysterious as infection had been. Surgery had come up against the third barrier. They called it shock.
The term shock is interesting. The picture was recognized during the Civil War. Stonewall Jackson was wounded in the shoulder when he was out front of his troops at the Battle of Chancellorsville, and Stuart McGuire, a surgeon from Richmond, wrote an account of how Jackson looked as he was brought back, and it's a classic description of shock. He was pale, he was hungry for air, he was gasping, his blood pressure, they didn't measure blood pressure, but his circulation was very poor.
Initially, people were skeptical that such complex symptoms could result from the loss of a lot of blood.
Many people considered shock, as we think of it, as a sort of psychiatric syndrome, a sort of psychological response to injury, and it took people a long time to realize it was just due to the fact that your lifeblood is on the floor.
Patients went into shock when their blood volume dropped below a critical point. But surgeons, particularly those working in the abdomen, were often unsure just how much blood was being lost, and when shock did occur, they had no way of replacing the blood.
A man would come in, a healthy chap who'd had a blood vessel torn, would have lost several pints of blood, and in spite of having skillful surgery and the artery tied off, because he was exsanguinated, he'd die. A woman would come in with a ruptured ectopic pregnancy, age 22, and in spite of having the hemorrhage stopped, the blood loss would be so great, the woman would die. And of course, people had tried over the centuries to transfuse blood. The very first blood transfusion was done by Richard Lower in Oxford in 1667, the year after the Great Fire of London.
The first transfusions were from animals to man. The lamb was usually the chosen animal because it was thought that some of the character of the donor passed to the recipient. According to Samuel Pepys, this did occasion many pretty wishes, as of the blood of a Quaker to be let into an archbishop. But when a French doctor was sued after the death of a patient who had received such a transfusion, the idea was abandoned.
And it wasn't until 1818 that a doctor in this very hospital at Guy's, Blundell, carried out the first human donor blood transfusion. Some were successful, many were disastrous, because of course they didn't know anything at all about blood groups, and so very often the blood was incompatible.
At first, the fact that some of the human transfusions were outstandingly successful while others were totally disastrous caused considerable confusion. But in 1900, Karl Landsteiner explained the contradictions. He recognized that there were a number of different human blood groups, and that the red cells from one group would be damaged by contact with the serum of another. Because this damage made the cells clump together, samples of blood could be tested for compatibility.
To find out a person's blood group, sera of groups A and B are used. To carry out the test, a drop of diluted blood of unknown group is mixed first with group A serum, and then another drop mixed with group B serum. The reaction can soon be read by the naked eye. If agglutination takes place, the red cells will be seen to form irregular clumps in the clear serum as seen on the left side.
The first transfusions of matched blood were very crude. Because blood clotted in air, donor and patient were joined by a tube. At first, no one had any idea of how much blood had passed across. By using a syringe, they were able to draw a known amount and inject it immediately. Now they knew how much they were transfusing, but it was hardly a practical arrangement. The difficulties remained unresolved until the First World War. Now large numbers of the wounded were desperately in need of blood. For the first time in this war, use was made of an anti-clotting chemical, sodium citrate. Using this, blood could be drawn from the donor and kept for transfusion sometime later. The awkward direct methods were no longer necessary. In Stalin's Russia, they hit on a highly bizarre source of human blood, human corpses. Because the blood of a corpse doesn't clot after death, the blood could be kept for several days. Thousands of transfusions were given in this way, but eventually, due to inherent ethical difficulties, it was abandoned. By the early 1930s, the idea of giving blood as a patriotic duty was established, and many people enrolled as donors through the Red Cross. At such a time, it was never considered that blood donors might need to be paid. The healthy gave blood freely for the sick. So now, the three barriers of pain, infection, and blood loss, which had hindered the progress of surgery, could be overcome, at least by the most expert. The very skillful surgeon could now expect good results, and to refine their skills, surgeons began to specialize. The American Harvey Cushing chose to work on the most delicate of organs, the brain, despite the fact that when he began, up to 70% of patients would die on the table. Cushing had studied with brain surgeons in Europe and had learned there to control bleeding with massive arrays of artery clamps and to use a toothed wire to saw through the skull. Even though blood transfusions were now technically possible, Cushing took great care to prevent excessive bleeding. He was the first neurosurgeon to use diathermy, sealing the cut ends of blood vessels with an electric current. And he made regular checks of his patient's blood pressure. In Cushing's hands, the outcome of brain surgery was transformed.
Cushing's technique in operating on the brain, I would think, has probably rarely been equaled. I'm not a neurosurgeon myself, but we had many expert neurosurgeons in our department, and I would say they all respected his abilities tremendously.
Cushing's outstanding qualities were also recognized in his own lifetime, so much so that two of his colleagues filmed a record of his 2000th operation. It was to remove a tumor of the pituitary gland, deep in the middle of the brain, an amazing undertaking with the facilities available at that time. The result of any accidental infection in the brain would be catastrophic. So the observance of aseptic techniques in Cushing's operating room was legendary. Despite the masks, he felt that any talking increased the risk of infection, so his operations were often performed in complete silence.
The operating rooms at the Brigham Hospital were pleasant, open places. They drew their light from the high, north-facing studio windows. The sounds and the smells of the street drifted in, and we recall one day when two small boys climbed up into one of the poplar trees just outside the windows to get a good view of all that was going on. When Dr. Cushing arrived to take over the operation, he apparently did not see the boys, although everyone else was aware of their presence and was wondering what would happen. When he uncovered the brain, the boys' excitement gave them away. The chief walked over to the window, and looking over his glasses, he said very sternly, "If you boys cannot keep quiet, I shall have to send you home." Needless to say, they became silent and stayed on till the end.
The operations often lasted many hours. As the after effects of deep ether anesthesia over such a long period could be severe, Cushing worked with a local anesthetic, with just enough ether to keep the patient unaware of what was going on. For a large part of his career, Cushing performed just one type of operation, the removal of brain tumors. By practice, he brought his own technique close to perfection. By the end of his career, Cushing had reduced the death rate following brain tumor surgery from 70% to a mere 4%. But Cushing was exceptional, the super specialist performing just one type of operation. And he was working in a top surgical center with excellent backup facilities. Most surgery was nowhere near as sophisticated, nor as safe. World War II was the catalyst that was to transform the practice of ordinary surgery in even the smallest hospitals of Europe and America. There were large numbers of wounded. In these conditions, it was certain that many of their wounds would become infected. And this acted as a powerful spur to the development of a new drug, penicillin, which could kill bacteria inside the body. From now on, the danger of post-operative infection would lose some of its menace. Once again, there was an urgent need for blood for transfusion, and the service was rapidly expanded. Large numbers of new donors were enrolled, and centers were set up to test and store the blood. It was now known it could safely be kept for some weeks before transfusion. After the war, this system would continue in place to supply as much blood as the surgeons needed, the first time they enjoyed such a luxury.
And as one writer said, blood transfusion went from the gill to the gallon in World War II. That's when we started to speak of giving people 2 or 3 or 4, 5,000 milliliters of blood, and it means 5 quarts of blood, almost equal to their normal blood volume.
The war also produced a crash program to train anesthetists to staff the emergency hospitals caring for the wounded. Yet the new recruits were just not experienced enough for the challenges they were to meet, as was tragically demonstrated in the surprise attack at Pearl Harbor, where the medical services were completely overwhelmed.
It was sudden, unexpected. There was a shortage of blood and plasma in the hospitals where the wounded were brought. And of course, many inexperienced anaesthetists would give the pentothal, which was easy, put them to sleep, and they tried to keep them asleep with pentothal. Now, unfortunately, pentothal given in any dose, but certainly in any large dose, produces a dilatation of all the arteries in the body. Now, if you're short of blood, that means that there isn't enough blood to keep up your blood pressure, and your shock goes worse. And in fact, the mortality due to those circumstances and the use of pentothal at that time on these patients, many of them were burnt, which is almost worse than blood loss from the point of view of loss of fluid. And the mortality was very high, and it has been said was higher, in fact, than the mortality from actual bullet wounds and damage.
The lessons were not forgotten. Many of the young men and women who had spent the war administering anesthetics decided to specialize when they returned to civilian life. They replaced the general practitioner, who had often been the only person available before the war. With their arrival, the whole basis of anesthesia changed, as drugs like ether came under attack.
In my early days, the 30s, all our anesthesia was basically done with ether, which is practically abandoned now. And we often used open cone ether. You take a cone, drip the ether out. It's truly primitive in present day thinking. But the patient had to be under very deep ether anesthesia. And of course, they had so much ether that their body's tissues were all saturated with ether, and they would sleep for hours and hours and hours, if not days.
The new specialists who were now taking over anesthesia asked themselves why they were saturating their patients with ether. It was not to control pain, that took very little of the drug, but to make the muscles relax. Without such relaxation, the surgeons had difficulty operating, particularly in the abdomen. But the cost to the patient of these massive doses of ether was heavy.
Ether is a pretty irritant drug to the lungs, but more important than that, the recovery is slow. And if you've had an abdominal operation, which inhibits your breathing anyway because of your wound, and you've got breathing depressed by your ether, with secretions which ether causes in the lungs, and you can't properly cough them up, you tend to get pneumonia. And one did see deaths from pneumonia following ether anesthesia.
A much more specific method of relaxing the muscles was lurking in the Amazon jungle. The blowpipes, which the hunters used to kill monkeys high in the treetops, fired arrows tipped with poison, and the poison worked by paralyzing the muscles of the monkeys, precisely what the anesthetists wanted to do to their patients. The active ingredient of the poison was the bark of a vine, and this was used by drug companies to make curare, which from the end of the 1940s became a standard part of the anesthetic whenever muscle relaxation was needed, as in this cesarean operation. With muscles paralyzed, the patient could not breathe for herself, but by now the anesthetist could do it for her. It was typical of the new scientific approach to anesthesia. With curare to produce relaxation, only very light anesthesia was needed. None of the curare got through to the baby, and the surgeon could work easily without worrying about the damaging effects of the anesthetic drugs. The whole procedure could be completed in a fraction of the time, with almost immediate recovery. If a mere 15 minutes after a major operation the patient could be wide awake and smiling, then surgery's horizons might be limitless.
150 years ago in this room, patients would only lie on this table in desperation when they were so tortured and in such agony from their gangrenous leg or their stone in the bladder that they'd submit to the surgeon's knife. And often then they'd lose their nerve and say, I can't go through with it, and leave, like poor Frederick Churchill did after his leg was amputated. And now with modern anesthesia, with antisepsis, with blood transfusion, with antibiotics, the modern miracles of surgery, nothing can escape. Everything from the brain to bunions is available for the surgeon's healing knife.
In barely 100 years, a gruesome and dangerous craft had risen to become a respected branch of medicine. Yet the achievements surgery had made by the end of the war would be eclipsed by what was to come. Surgery was about to enter its golden age, an age in which the surgeons would penetrate hitherto forbidden territory, like the heart, and begin a revolution which would culminate in operations like this. Back at the Boston Children's Hospital, 5 hours have passed. 5 hours of intricate surgery, and baby Travis now has a properly constructed heart, correctly connected to his vital blood vessels. A surgical team with skill and courage has taken a baby facing certain death and given him a chance for a normal life. Next time on Nova, the pioneers of surgery go into the heart, developing the first daring operations which led to the miracle of cardiac surgery.
It was very risky and required a very special kind of personality. People who had enormous self-confidence, who understood what they wanted to do so well that they understood that it could be done.
Some took very great risks indeed, connecting a sick child to a parent who acted as a human heart-lung machine, taking the child's blue blood and returning it red, allowing the surgeon to work on the open heart.
He said, Dr. Lillehei, your name will go down in history as the first surgeon who ever developed an operation with a 200% mortality.
Into the heart. Next time on Nova.
And next time for Nova, as we continue this series on surgery, will be Tuesday evening at 8 and next Saturday afternoon at noon. And continuing this Saturday afternoon, a National Audubon Society special examines the American farm, the way of life, the methods of raising crops, and the future of the world, all in an hour. That'll be the program in an hour. It starts in just a couple of minutes today. And that'll be followed by Hollywood. Today, an assessment of the early days of the silent film eras. We'll see excerpt from Cecil B. DeMille's The Squaw Man and D.W. Griffith's Intolerance. That'll be at 2 o'clock today. And there'll be nature tonight. Under the Stars, we'll go camping on Mount Fuji and take a look at some of the endangered species of Japan and what the Japanese government is and is not doing about it. And Monday through Friday, we start a new conversation series, Bill Moyers in Conversation, with different people, thinkers, writers. We start off with filmmaker David Putnam in Profile, and in Conversation Monday, 7:30.